Good afternoon. Thank you for attending the Season 8 finale of OCHIN Grand Rounds. I am your host, William Pinnock, and today I could not be more excited to welcome Dr. Danielle Hessler-Jones and Holly Wing of the University of California, San Francisco, as they present on comparing implementation strategies for social needs programs, also known as the CRISP study. Dr. Danielle Hessler-Jones is co-director of the Social Interventions Research and Evaluation Network, also known as CHCs, and a professor and vice chair for research in the Department of Family and Community Medicine at the University of California, San Francisco. Her research focuses on social care delivery in the healthcare sector, including understanding the impact and implementation of programs aimed at screening and addressing social risks alongside programs that seek to adjust care to fit an individual's social context. You can find her published in such places as, to name a few, American Board of Family Medicine, Journal of General Internal Medicine, and American Journal of Preventive Medicine. Holly Wing is a research analyst and clinical research coordinator with the University of California, San Francisco Center for Health and Community. She provides research support to Siren and curates content for the Siren website database. Ms. Wing currently coordinates the Health Advocates 2 study at the Zuckerberg San Francisco General Hospital, examining the health and utilization impacts of systematically addressing the family's social determinants of health in the context of pediatric urgent care delivery. You can find her work published in such places as Journal of the American Board of Family Medicine, American Journal of Managed Care, and Journal of the American Medical Association Pediatrics. This session is being recorded. Attendees are muted upon entry, so please pose your questions through the Q&A or chat box. This presentation will last approximately 40 to 45 minutes, with 10 to 15 minutes at the end to answer any questions you may have. We will now pass the mic to Dr. Danielle Hessler-Jones and Holly Wing for comparing implementation strategies for social needs programs. Dr. Hessler-Jones, Ms. Holly Wing, the floor is yours.
Hello, everyone, and thank you so much for joining. I had no idea till now that we were the finale for the season, so that feels extra special to be here with you today. As you heard, I'm Danielle Hessler-Jones. I'm here with my close colleague, Holly Wing, and it is our true pleasure to be sharing results and findings today from the CRISP study that focused on comparing implementation strategies for social needs programs. And so I know that acknowledgements often go at the end of a presentation, but I'm a person who really likes to eat dessert before dinner and acknowledgements before the presentation. So first and foremost, I want to do some recognitions. I want to recognize all of the clinics who made this possible within the OCHIN network. And so these were individuals on the front line of social care delivery, clinicians, leaders at clinics who took their valuable time to give us their insights, give us their perspectives that really helped our learnings that you're going to see here today. I also want to acknowledge our amazing partnership. So at Siren at UCSF, this work was a true partnership alongside our colleagues at OHSU, ORPRN, the Oregon Rural Practice Research Network, and of course, our many colleagues at OCHIN, and our funder, AHRQ, the Agency for Healthcare Research and Quality, as well as acknowledging that the research reported in this work was powered by PCORNet, which is developed with funding from PCORI, and really wanted to acknowledge that key role of conducting this with Advanced Clinical Research Network. As you're going to see throughout this presentation, the OCHIN is in this incredibly rare and amazing space to be able to pull together insights and data that allow for the progressing of the work in this area. So our sincere gratitude. So let's jump in. Before we get to talking specifically about what we found in CRISP, I just wanted to do a little bit of zooming out, a little bit of big picture. So There's, as you likely already know, there's increasing recognition that health and health equity are powerfully shaped by social and economic environments, and that this has led multiple federal, state, and local agencies to recommend, and in some circumstances actually require, that healthcare providers identify and address what we refer to as patient social risks. So these are questions that ask about an individual's food insecurity, housing instability, transportation needs, or other social circumstances. And these activities are increasingly being tied to payment structures. In fact, just this year, NCQA and CMS introduced measures intended to incentivize social risk screening and in some cases interventions, as you see here. And these were launched as voluntary last year, and then they transitioned to required reporting as of January 2024. However, despite these new policies and measures and EHR documentation options and electronic referral platforms, there's still little that's known about how to maximize the implementation and sustainability of social risk screening, and how to do this and at the same time account for the limited clinical resources and the burden of these programs on clinic staff. And so that's really at the heart of what we were trying to do in the CRISP study. We were trying to understand how different implementation support strategies could help with social risk screening, could help with that uptake, or whether they helped. And when we go to the literature in general, when thinking about innovations and uptake of things like screening, points to two main strategies in terms of implementation support. First is financial incentives, providing some form of money. So sometimes money talks. You do an action, you do a behavior, like you complete a screening or you're up to date on something, and you get that financial reward. The other is called by many names, but often called by something like practice coaching or practice facilitation. And that, in contrast, is the hands-on support. That's when often a coach or a team, an implementation team, is working hands-on with a clinic to provide assistance, including technical assistance, working through workflows, PDSA cycles, all those decisions to work through those problems as they come up. And so while these two strategies have been often tested in primary care settings for other topics, they not much is really known about them when it comes to social risk screening and social care activities. And so we counted ourselves as very fortunate to be able to leverage the confluence of two big initiatives that were already happening. So we didn't create these were happening, and they also happened to start up around the same time. We're doing a little time machine moment and going way back to 2018. Back in 2018, the Accountable Health Communities, or AHC, which some of you may already be familiar with, started up. And the Oregon site for AHC elected to provide financial incentives along with some light implementation support to clinical delivery sites, to clinics who were completing screenings. So clinics that were involved with the Oregon AHC grantee could apply and receive reimbursement, $10 per completed screen in the first year after starting implementation, and then $2 per screen the subsequent 30 months. So it started out at 10, then dropped to 2. They also received $100 per client who was receiving navigation services if they screened positive and desired navigation assistance. So that allowed us an inroad to understand what might the impact of financial incentives be. At the same time, the OCHIN-led Ascend trial was starting up. So this is an implementation trial where clinics who were involved and onboarded received 6 months of more intensive implementation support. So they worked with a trainer or a coach, and they worked with them over the course of 6 months around the adoption of social risk screenings and using EHR-based documentation tools. And the ASCEND trial has been already evaluated. You may have already heard about it within your network and the positive findings of it having an impact. But what we did here is we were able to look at not just what the impact of it was, but alongside and in comparison to the AHC financial incentives, and down here in the bottom right-hand corner, the natural overlap between clinics who raised their hand and signed up for both the Ascend and the AHC initiatives. So in summary, there were naturally occurring circumstances that allowed for 6 clinics to be only receiving financial incentives, 19 clinics to be only receiving practice coaching, 7 clinics who received both. And then we put together, through a lot of fancy stats, a control set of clinics, the comparison clinics that did not sign up for either initiative, weren't involved in either. They weren't getting practice coaching, they weren't getting financial incentives. And we asked 2 questions. We asked, do financial incentives and practice coaching actually influence the rate of social risk screening? So like if you pour on these supports, does it make a difference? And which one? And what's better? And we also asked, what other supports do clinics need to help them screen for social risks? And so here's a quick description of our clinics that were involved. You see on the left the control comparisons, and then the middle column is all the clinics that are involved either in AHC or Ascend. They were getting some form of implementation support. So you can see quickly here that most of them came from an urban setting. 2/3 were identified as FQHCs, around 1/3 county health department. About 2/3 had social services on site, but I want to really draw your attention to that bottom line. That's the social risk monthly screen rate per 100 patients. So this is at baseline. This is where folks were starting out at back in 2018. And so what you see here is where they were starting out was about 3 patients out of every 100 were screened per month. So fairly modest starting points. They were engaged in screening, but fairly low. And that's gonna, I'm highlighting that because that's gonna come back around and be important here later on. So on to the results. Well, we first asked, okay, well, what's the impact of any kind of implementation support versus none? So we first looked at comparing all 3 of these green boxes. You got any form of support versus no support. And we asked, did that have an impact? Did that result in clinics engaging in more social risk screening? And the short answer is yes, it did. Clinics that received any form of intervention versus none had greater, though admittedly small, increases in social risk screenings. And so to put this is what's called a difference in difference test. So it was looking at the change over time. It was looking at this monthly rate per 100 patients. And so if we take that first number in bold on the left, that's at 12 months after the intervention started, the implementation support started. And what that's saying is that the increase in average monthly social risk screenings was a little over 4 patients out of every 100 greater in the intervention clinics than the control clinics during that first year after they got the supports. What was really nice and encouraging that we saw is that this continued out at 18 and 24 months. So by 24 months, it had been 18 months since those Ascend implementation coaching supports had been removed and wrapped up. And the AHC monetary reward was down to $2, which is, very, very modest financial incentive. And yet we were still seeing that those clinics were screening, between 4 and 5 patients on average more than the control clinic. So a modest effect that did extend to 24 months, though not all the way out to 55 months at the time where we wrapped up data collection. Encouraged by that initial finding, we also wanted to take a look at the financial incentives alone. And so we compared these top 2. saying, okay, any implementation support that had an impact, what about just financial incentives versus controls? There, we did not find a statistically significant difference or rate of increase. So clinics who received only financial incentives through HC did not have greater increases in their social risk screening rates than clinics receiving no intervention. And then finally, because we had this confluence of events where some clinics were signed up to receive both forms of support, both these financial incentives and the practice coaching, we wanted to ask this question: are two things better than one? If you got both forms of support, did that lead to more screening than receiving just one form of support or the other? And what we found there is yes, kind of. So we had, because this was a naturally occurring study, it meant that some clinics started off receiving the financial support and then got the coaching layered on. So that's that top row. And other clinics started off with coaching and then got the money, got the financial reimbursement layered on. And we found that it was a significant positive impact in screening when clinics started off with getting the money and it had some impact. And then they got the coaching and it had an additional significant impact. So there, at least at 12 and 18 months, and it was like a trend at 24 months, we did see that positive impact of the additional impact of practice coaching on top of getting financial incentives. The other way around, when it started off with coaching and layered on the addition of the financial incentives, the point estimates were larger, but the confidence intervals were really large. So some of these were p-values were close, but not statistically significant. So, in summary, for our findings, you can think of this in two ways. You can think of it as glass half full, in my opinion, and you can think of it as glass half empty. So on the glass half full, we found that receiving any intervention versus no implementation support and the additional layering of practice coaching on top of financial incentives doubled CHC's monthly social risk screening rates the first 18 months following intervention. At the same time, the practical significance of these findings is unclear. Given those low base rates of screening that you may remember a few slides ago, a doubling really, might sound impressive, but it meant that clinics were only screening 4 to 5 more patients per 100 per month following this implementation support. So in summary, we felt like this impact was in the direction that we hypothesized and thought, but it wasn't necessarily as strong as we expected. And so we then went to our qualitative analysis to help us try to contextualize these findings, to help us better understand what might be going on. And who's better to tell us what might be going on than folks on the front lines themselves who are doing this important work. So we did qualitative interviews, and Holly Wing, who's here today, did a lot of these interviews personally. These were with 12 of the clinics participated, so a subset, and you'll see here that they represented clinics that were involved in the financial incentive, AHC part, the Ascend, coaching part, and both. And there were 42 interviews in all. I want to recognize that this was during a time of late 2020 to 2021. So you can think back to all the confluence of events that were going on during that time. And then admire that folks took the time to talk with us during that period of time. These included administrative leaders, clinicians, and frontline staff, including those who were conducting social risk screening and navigation. And we first asked folks really about their perspectives on screening and addressing social risks. And for those interested in learning more, I'll highlight that these findings are published by, and in this paper here, we were trying to do quality versus quantity, challenges and opportunities at the intersection of standardized and personalized care in community health centers. but I'll just lift up a few of the highlights and takeaways from that work. We really saw very and heard very clearly that social risk screening and follow-up care align with existing CHC practices. Talking with patients about their social risk factors, individuals told us again and again in the interviews, is deeply embedded in the mission of CHCs and the work that they're doing. At the same time, new policies that are trying to standardize related activities could feel at odds. So this idea of doing these very standardized sets of screening questions and documenting them in a very specific way there was a tension there, and it could feel at odds with existing workflows and ways of having more conversational practices that were more informal and that led in some ways to more relationship building with patients. And so a couple of the takeaways that we heard come through in this work was the need to acknowledge local knowledge about patients' lives and the resources available, and that these should not be deprioritized in the rush to create quantifiable EHR-ready data that could be compared. We also heard the call that responding to newer social care policy incentives must account for how social care is already conceived of and already being done at clinics. And that ideally that this could be incorporated and incorporate more informal practices and conversations that staff are committed to, that have already been doing and are planning on continuing doing, and having that interwoven with the strategy for national standardized documentation goals. And then to turn to think more specifically about, well, why would the financial incentives not have had as much of an impact as we might have thought? Because I got to tell you, Laura Gottlieb, who has really led the CRISP study. When we were initially talking about this study and applying to AHRQ for this, we really thought these financial incentives we thought that was going to be the group. And boy, as you saw in the results, that's not the way it went. So we also took a deeper dive in qualitative work to understand what was going on with those financial incentives. And one of the things that became clear very early on was there was not a lot of awareness about the financial incentives. Frontline staff, who were the ones that were mostly responsible for doing the screening, for doing the navigation services, to working hands-on, were largely not aware that financial incentives were at play, that the clinic would be receiving money for these activities. And even when thinking and talking with administrative staff, even when there was an awareness that there was a general payment, they often weren't familiar with the specific dollar amounts, nor were they often aware of how the money was coming into the clinic and being applied within the clinic. We heard some mixed results in terms of a perception of whether or not incentives at any dollar amount may or may not have an impact on social care uptake, on things like doing social risk screening. And for those who were feeling like it would not have a large impact, there were three main themes that came up. First, at least in the case of the AHC dollar amounts, this $10 screen, and then reducing down to $2, it was pointed out that these financial incentives are just not large enough to overcome clinic level barriers to adoption. It's too much of an ask. It's too much documentation given the dollar amount. Second, we heard that it's just not relevant that CHCs are doing this work. They have been doing this work. They're going to be doing this work. It's at the heart of their mission of their work. And so getting an incentive in some ways just didn't align with any sort of motivation to do something differently. They were already invested in this work. And they highlighted for us, they didn't want the incentive tied to just some patients. For instance, Medicaid or Medicare. They wanted to do this for all patients. And then last, there was a concern that social risk screening in some cases wouldn't meaningfully affect patients' lives. And this came up in the context of not having available resources and not being able to address the identified social needs. On the flip side, there were some folks who told us about more motivating uses for the incentives. So they said, that's how incentives did play out. But if I had a magic wand, if I could have structured financial incentives differently, here's how maybe we could have made them have more impact. Increase social care staff. So give incentives, financial drivers that allow for hiring people, for hiring specifically the social care staff to work directly with the patients and deliver social care, whether it be screening or navigation services or otherwise. And consider giving the money to the patient. So we heard from several respondents, if you told me that this $10 would go directly to the patient for filling out the screening, that would have been a motivating factor as opposed to it going to me or going to the clinic. So that is what we found in CHRISP. And so now what I want to do is turn it over to my close colleague, Holly Wing, who's going to tell you a little bit about an additional step we took. So you may remember at the beginning that we were interested in the impacts of practice facilitation and financial incentives. We also wondered what else? What other sorts of supports or factors might be important when it comes to social risk screening? And so Holly, take it away.
Thank you, Danielle. Thanks so much. So as Danielle said, since few clinics in the Ascend and HC interventions have been able to achieve either high or high sustained uptake of documented social risk screening, we thought, wouldn't it be great if we could talk to clinics who are doing a lot of screening? So the high adopters, clinics with the highest rates of social risk screening throughout the OCHIN network. We hoped this approach would enable us to broaden our understanding of screening facilitators and learn about other implementation strategies CHCs employs to strengthen and sustain their social care activities. So next slide. We identified and invited clinics with high documented SDH screening rates to participate in this phase of the project. And we talked to administrative leaders, clinicians, and frontline staff from 5 clinics. Next slide. And we found that participants across CHCs, these CHCs highlighted both external and internal factors that influence screening activities in their clinics. External factors included operating in a state with a focus on social determinants of health, accountable care organization membership requirements and priorities, and primary care medical home certification requirements. Interviewees from 4 of the participating clinics indicated that their organization was a member of a statewide CHC consortium, and that these consortia provided a forum in which members could share strategies and troubleshoot challenges with social risk screening and social care. Internally, all participating CHCs operated using strong team-based care models, and they applied these models to their social care initiatives. Responsibility for implementing social risk screening was often distributed among multiple members of a given care team and seen as a collective endeavor. At several of the clinics we spoke to, medical assistants, often tasked with screening, were involved in decisions about implementation and contributed to workflow revisions to improve screening rates. MA's responsibility for screening and follow-up was often described as empowering, conferring a sense of ownership and pride to the MA, and is linked to an organizational culture valuing MA's work. Efforts to implement social risk screening were also buoyed by robust organizational level quality improvement efforts. These clinics were already using QI to improve care across a range of clinical activities. They then harness that capacity to support social care practices, engaging in plan, do, study, act cycles aimed at improving social risk screening rates, using screening data to provide health center, group, and individual level performance feedback. Communicating performance metric on a regular basis functioned as a mean of initiating conversations among leaders and staff to remember to screen, or figure out what wasn't working and make changes. We also heard, not surprisingly, I think, that staff commitment and support of screening was linked to the availability of resources for patients in need. In response to concerns that asking about needs that could not be addressed might cause harm, some clinics adjusted screening tools to include only questions about needs they felt that they could address. Though not all. Overall, those involved in screening at the patient level describe the importance of clearly articulating to all involved staff and to patients the rationale behind screening and the availability of resources. Next slide. So as our team looked at what we were hearing, it really stood out that several of the internal influencing factors map to the 10 building blocks of high-performing quality care model for practice innovation. These building blocks include 4 foundational elements: engaged leadership, data-driven improvement, empanelment, and team-based care. These foundational elements support the implementation of the other 6 building blocks. In this work, multiple internal influencing factors aligned with those foundational blocks you see highlighted on this slide: team-based care, data-driven improvement as seen in QI efforts, and engaged leadership, where high-performing practices have leadership at all levels of the organization, just like we were seeing across teams in relation to social care. Applying this model may shed light into what is working in these high adopting clinics. These foundational blocks need to be in place to drive successful innovation, and policies focused only on SDH screening without investment in the building blocks of high quality primary care. Ah, did I freeze?
I think just for a second.
Oh, okay. Well, I think we can go to the next slide then, Danielle. So, in quick summation, from our interviews with high adopting clinics, our takeaways are that sustained social risk screening in CHCs depends on a complex suite of external encouragements and internal capacity. To succeed, national and local policies intending to incentivize social care practices should deeply invest in the foundational building blocks that support high quality care. And with that, I'll turn it over to you, Danielle, and please let me know if there's anything that I missed when I
Thank you
froze. Sorry about that.
so much. No, I think we only missed a few seconds there. Thank you so much, Holly. And so in summary, thinking across these different stages of the CHRIS project, from looking at those screening rates to getting to sit down and talk with staff and clinicians and leaders about their thoughts and perspectives on this. And then as Holly illustrated, getting to connect with clinics that were not involved in these particular implementation supports, but that are screening at high levels and seeing what are the factors they're identifying. In summary, and thinking about this across all this work, here's a few of our takeaways. As social risk screening becomes increasingly tied to policy and payment, it's critical to identify strategies that can support clinics to implement screening and follow-up. So it's clear that we didn't find, when it came to financial incentives or practice coaching, that this was enough, that there was one magic ingredient that we can point to you today. The financial incentive and practice coaching supports that were provided individually and for some clinics in combination did contribute to statistically significant, but yet relatively modest changes in the number of patients that were screened for social risks. We think that the cumulative findings here support that when it comes to social care activities, there will likely need to be coupled foundational investments in primary care infrastructure in addition to these types of supports. And last, we want to again recognize OCHIN member data are uniquely valuable for understanding how policies impact clinics. There's a lot of policies that are occurring right now that are coming and that may be coming down the line in the next year or two. And we're so grateful that this network is in a place to contribute to this understanding and learning in real time. I'll quickly plug again, as William said at the beginning, that there is a flyer that we've created in partnership with amazing OCHIN colleagues that summarizes some of the key findings, and that's going to be sent out. I believe early next week, following this webinar. So we hope that you have a chance to look at that. We also welcome you connecting with us in any way, shape, or form. I didn't put carrier pigeon on here, but you name it. Reach out to us by any means to connect with us about this work, to connect with us about other work. Our website here at the top is a great starting place. We have an evidence resource library to look up literature. We've got a newsletter that highlights a research roundup each month that highlights some of the current findings. And we've got a webinar series where we would love to connect with you too. And now it is my great delight, before we go to your questions, I am so excited that Ned Mossman, your Director of Social and Community Health here at OCHIN, and Wyatt P. Benskin, Research Investigator here at OCHIN, as well as Adjunct Assistant Professor at Case Western Reserve University, are here with us today to give some of their take and reactions on what you heard about here today. And so I'm first gonna turn it over to Wyatt here for some thoughts on the research considerations.
Yeah, thank you so much, Danielle, and thank you, Holly. It's a pleasure to be able to just give some thoughts and I think, digest this really important work. I jotted a few notes, so if you see me looking down, it's so I don't drone on for 20 minutes because this stimulates so many thoughts and energy around this topic. One thing that I think is really important about the CRISP study and what it highlights is the unique ability to take advantage of these policy changes from a research perspective. I think the timing of that study, how it coincided with not just OCHIN's footprint in Oregon and the AHC implementation, emphasizes that we need in research to keep up with this policy change, to see these policy changes, which I feel like happen near daily now, especially in this space, are opportunities for natural experiments, for studies, to try to understand not just how they're being carried out, but how might other members be able to take advantage of them. So I think that from a study design perspective, I think that it really hammers home the importance of really being keyed in to those policy developments to be able to do what you all did so successfully, which was take advantage of this natural experiment and policy via a research grant and project. So that was a big takeaway from me is to try to keep up, take a sip from the fire hose of social risk policy work. The second thing that I think really jumps out to me is thinking about where to go from here, and really that idea of scalability. How do these findings translate to be able to support clinics that aren't participating or under an AHC model or umbrella. And importantly, I think too, what jumped out is understanding those clinics that aren't even able to participate in our research studies. We know that participation varies a lot within the OCHIN network, and so those that don't feel as though they're equipped to be participants, how might their needs differ a little bit, and how might our understanding of that financial versus practice coaching balance shift based on even who is participating in both our quantitative and qualitative studies. I want to call out that, there's a really big piece going on now, or work going on, led by Rachel Gold and Laura and others, about simplifying the tasks. So, what is the lift of a provider or a clinic in conducting that screening? Can we make it easier on them? Can we use EHR-based tools to make the screening and documentation and referral and in an ideal world, a closed loop, fully realizable in a way that doesn't burden the providers, that's easier for the clinic, that makes that even just $10 incentive that much sweeter to clinic leadership to build in those tools. And the last I think area that jumped out to me was and as I transition over to Ned, this is I think an area of overlap here is really ensuring that these policies have equity embedded in them. I think your work not just has implications on how we're supporting our members, but really calls attention to how much a $10 AHC incentive may not make a huge difference or may not make the difference that policymakers hope that it would make. Especially, we see the increase and that's great, but the bullet point that you had about like, what does that actually mean? And I think to a lay audience that is not thinking of this through a research lens, they'll say, we spent a heck of a lot of money on this program and this is the only increase. And so I think, ensuring that equity, that those incentives align with what would motivate change in the clinics is something that your study, Danielle, I think has really done a wonderful job of uncovering and saying that these models are great and they do make a difference, but it's not quite enough. And I think finding a way to continue to study that question of what might be enough in either the practice coaching or the financial incentive is fascinating. So I have a lot of thoughts. I could talk forever, but this was a wonderful presentation and really wonderful work. And I'll hand it off to my colleague and friend Ned for his thoughts.
Thanks so much, Wyatt. And I'll just second, thank you so much for having us as part of the discussion. And I think it's really interesting to some of the points that Wyatt made, and also to the barriers that you heard about during CRISP. The AHC, the Accountable Health Communities grants, were an interesting cohort for CRISP to look at, just because of that financial reimbursement, $10 a visit for the first year, and then down to $2 per screen. It may be that's just not enough to incentivize folks. And as I've said, you can imagine a pendulum where it's $0 probably isn't enough to do much motivation, but probably $100 would. And so where in between does that really kick in? And I see I was examining the comments earlier and saw our colleague here at OCHIN, Arwen, mentioning that sometimes people getting reimbursed may challenge the values that they're bringing to the table and the motivation for doing this work. So it's possible that it may not, it may be at odds with that. So that's an interesting thought. But I think we're going to see with the Medicare fee schedule that came out for 2024, this calendar year, starting January 1st, folks can get paid, reimbursed for doing assessment. It's not really screening. So you actually need to have some sense that the patient may have one of the social needs being screened for that's affecting their health. And there's also an expectation of follow-up. But that addresses one of the other barriers that was mentioned, that, that screening may not make much difference, especially if it's not being acted on. And I think the way that Medicare has constructed this, so it's roughly twice the amount of that $10, and they can do it every 6 months, not more frequently than 6 months. And then it's tied to a different G-code. There's an expectation of follow-up for identified needs, and then those community health integration services that would be could be used to navigate and respond to new care coordination and even direct service provision to some extent is reimbursable. And up to, I think it's like an hour a month, so up to 60 minutes a month. So there may be more of an opportunity to see some incentive, both a little more money paying for.
I think we're losing you a little bit there, Ned.
Oh, sorry. Am I clear now?
You're coming through again. Yes.
Okay, okay. My apologies. Anyway, I think I'll think we'll be able to make some interesting comparisons with data that's so I'm really interested in the opportunity to look at this down the road.
I love that you raised that. And that's such a great example of how policies, as both of you named, are constantly evolving. You know, it's hard to keep up with them, and they're in real time, as you noted. Both the difference of the dollar amount, the doubling of that $10, and perhaps more importantly, as you pointed out, it's not just about the dollar amount, it's also about how that's interwoven with the follow-up and the expectations of how it's integrated in. Thank you both so much for those brilliant insights and reactions.
Thank you, Dr. Hessler-Jones and Ms. Holly Wing, for that fantastic presentation. What a way to end our 8th season of OCHIN Grand Rounds. And thank you to everyone who attended today's session. For those in attendance, please be sure to check your email in the next few days for a copy of the crisp, high-level summary learnings flyer. And you can connect with Siren over on their website at sirennetwork.ucsf.edu. That's SIRENETWORK.UCSF.edu to access their evidence resource library and links to their X, YouTube, LinkedIn accounts, and the Siren podcast. Also, please be sure to follow OCHIN on Instagram at OCHIN Network and over on LinkedIn. In addition, head over to ochin.org and advancecollaborative.org to read the latest on our research studies, blog posts, and upcoming events. And don't forget to visit our OCHIN YouTube channel to catch up on those past Grand Rounds presentations. And OCHIN Grand Rounds will be on summer break for the next few months to get prepared for our 9th season, which we will be kicking off on September 26th with Dr. Eva Woodward of University of Arkansas Medical Sciences and Veterans Health Administration, presenting on mindsets to promote health equity through health services and implementation research. Invitations to this presentation will be sent 2 weeks prior to the event, but if you're not on our mailing list and are interested in attending this or any future event, please email me at grandrounds@ochin.org. That's grandrounds, all one word, grandrounds@ochin.org. So from all of us at OCHIN and Dr. Hessler-Jones and Miss Holly Wing, to all of you, have a wonderful rest of your day, a happy and safe summer, and stay healthy out there.